what is your medical? Sometimes I get confused because మీ సార్ ఒకటి చెప్పి నేను ఒకటి చెప్తే మళ్ళీ మీరు కన్ఫ్యూజ్ అవుతుంది.
Just one. I want to just personally give you a copy. This is our casebook which we published now.
Congratulations.
Of course, sir. Thanks to you, sir. You are all the contributors and practitioners.
Good.
And also some product brochures, samples, around 10-12 products. We have started, our marketing team has started sharing this with referring physicians.
Thank you. So, why that is important is the natural history or disease what you are dealing will depend upon it. Some diseases are there which are 10 years history. Some diseases are there which 1 year history, right? So some disease is there with 20 years history. I tell you it is valor artist. What is it more likely? Valor, what is more likely? Rheumatic only. Valor means generally we consider rheumatic. Rheumatic, what is more likely? Long disease, short. I told you before. Suppose somebody is coming with history of 20 years. Valor disease. What valor disease is more likely? Mitral valve disease, either mild, moderate mitral regurgitation, mild stenosis, moderate mitral, something like that. Long history. The aortic stenosis generally will have short history. Enduku aortic stenosis, once symptoms start, they have deteriorated 2-3 years. It cannot be like symptomatic. Asymptomatic aortic stenosis can be long again. They can be years together, asymptomatic. Once symptoms start, deterioration is very fast. I have told you the 2-3-5 years story. You should mug that up here. Everybody should know it. What is the 2-3-5 year story of aortic stenosis? You don't know? I did tell before. I will not progress discussing new things if you forget what I have told. I am 100% sure I told this in an aortic stenosis case. And then please note down somewhere. That's how you have to learn. It is I learned it like that. Otherwise, this process will again get stuck. The same thing we discuss again. How will you discuss the new things? I tell you when I took that aortic stenosis case, how will you assess the severity of aortic stenosis? I did tell it's the triad of symptoms of aortic stenosis. Exertional angina, exertional syncope, and exertional dyspnea. Yeah, you would have to go to I did tell this, right? I categorically remember. No, that's what is the wrong thing. Remember. Worst is what? Worst is dyspnea. Heart failure means dyspnea. That's the worst. 2 years. Okay. Angina is 3 years. Syncope is 2 years. Sorry, 5 years. So syncope, angina, and breathlessness. 5, 3, and 2. 2 years is worst. Breathlessness more than that, patient cannot live more than 2 years. Generally, by and large, patient will die unless treated. So, if a patient has short history, it indicates it is the aortic stenosis valve disease. Long history, mitral valve disease. It can be anything. It's a mixer, combination, anything is possible in medicine. But what examiners will generally try to assess is what is your overall concept of disease. Your diagnosis is totally wrong. Finally, what you tell, they're not bothered. Your presentation is good, your analysis is good. Generally, your knowledge base is good and good and fast. That's what you need to assess. Very few examiners who are cranky might fail if you are finding it wrong and all that. They don't assess that. How we are presenting history? What are your concepts? What are your thought process? How did you arrive to come to it? On the other hand, you tell something else and tell some other diagnosis, correct diagnosis maybe, still they may fail you because they think that diagnosis is fed. Because what you presented is different, what you finally diagnosis is, that is wrong. So what I coming back to 10 days and what I should think? I should think of something acute. No? First statement can be 10 days because patient told 10 days. Patient is telling you, a problem I am not 10 days, just 10 days. That is okay as a presenting of our complaints. Apparently asymptomatic, like you have to use your conscious knowledge. Then you should tell that. The totally diagnosis will be different compared to 10 days. 10 days at I think it is coronary arteries in that age, 60 years. No? 60 years, chest pain, but what do you think? Acute MI, elevation dysfunction, heart failure. 10 days, that is more likely. 10 days and you tell that it is mitral valve disease, then it is not correct. No? So correctly, that's why you are supposed to tell. E patient get anta cheptundi, she is telling you the diagnosis also. I wanted to discuss natural history of disease, mitral valve disease in this patient. Everything is like how would it describe in one word? She is like that. If you have seen this lady in detail, so that, okay, if you are not correct, please go through the records. You will never ever forget natural history of mitral valve disease. Atlunda patient. నేను కూడా చాలా ముసలి అన్నట్టు కనిపిస్తుంది చూస్తే ఎందుకంటే ఫస్ట్ టైం when she came, my writing is there. Horrible writing. Pratimamadi. I was a professor in Pratimamadi, I was long there. I need to go on that. చూశాను తర్వాత ఇక్కడ పిలిచాను వన్ ఐ ఫీల్ వెరీ గుడ్ అబౌట్ సమ్ పీపుల్ అప్పుడు మా మదర్కి అంత అఫోర్డ్ లేకపోతే సార్ మీరు హెల్ప్ చేసి ఆరోగ్యశ్రీ తెప్పించి CMD తెప్పించి చేసిండ్రు నేను సాఫ్ట్వేర్ సమ్ సన్ బికమ్ సాఫ్ట్వేర్ ప్రొఫెషనల్ నౌ వీ కెన్ అఫోర్డ్ సార్ ప్లీజ్ గుడ్ ట్రీట్మెంట్ ఫర్ మై మదర్ ఐ రియలీ ఫెల్ట్ సో హ్యాపీ ఫర్ దట్ కిడ్ అండ్ దట్ ఫ్యామిలీ అప్పుడు మనం చేయకపోతే ఆ పిల్లోడు లేడు వాడు కాదు ఫ్యామిలీ స్టేజ్ కాదు సో ఎడ్యుకేషన్ మేక్స్ లాట్ ఆఫ్ డిఫరెన్స్ that also pregnancy based problem in India of common time detected already. Okay, so coming back, what is that apparently asymptomatic thing makes a totally different diagnosis. That's why you should be careful in putting it correct. Okay. So patient is apparently asymptomatic 25 years back, 20 years back, whatever. And you noted to have consciousness during your second pregnancy, third, whatever. I'm just telling you that is there or not. So you have to tell more.
Past history.
You want to tell in the past. Generally, what is dictum is, which is unrelated risk factor. So totally not related to present history. Okay. About tuberculosis and chindo. Okay. Adi past history. Generally, that is the idea is to give a good flow. Whatever it is, I don't know if your medicine professors are asking you to tell like that, get to tell. By and large, the idea of making it is this, right? So, put it unrelated, you can tell in the past history. Patient attained menarche at 12 years of age, I am not bothered. Okay, that we can tell personal history, past history, whatever. But anything related to present history, it would be better that you tell it like a story. Okay.
Patient was apparently asymptomatic 20 years back. After which she was diagnosed in her first pregnancy, some heart disease for which she was treated medically. And as per what patient told us, she underwent some angio, she was told us. For which after that she was fine. She was taking medication.
మనం ఏమి చేయాలంటే చెప్తాం మీకు డైరెక్ట్ గా నేను ఇంటి ఇచ్చినా చెప్పదు ఎగ్జామ్ గా తెలియదు కదా అందరికి అర్థమైంది చెప్పదు కానీ అమ్మ యాంజియోనా బెలూనా అని అడగాలి బెలూన్ ట్రీట్మెంట్ చేసింది సార్ అంటారు అప్పుడు పేషెంట్ ఎందుకంటే దట్ ఈస్ నాట్ యాంజియోగ్రఫీ ఇట్స్ వైలర్ ఆర్టిస్ ఫస్ట్ మనకు తెలియాలి వైలర్ ఆర్టిస్ మనం బెలూన్ చేస్తాం అప్పుడే అడుగుతాం ఎవరు అడుగుతాం యూ డోంట్ నో ఫస్ట్ యూ షుడ్ నో దట్ బెలూన్ వాటర్ is done for rheumatic stenosis. Diagnosis is clear with that straight. You got the diagnosis, you're so good that no, that means what is the likely disease which gets precipitated in pregnancy?
Stenosis.
Regurgitation.
Mitral.
Social collapse.
Regurgitation. Mitral regurgitation.
Correct. Which gets precipitated during pregnancy? I'm asking.
Regurgitation also.
Regurgitation precipitated. It was final year, final year, second year. Under first year. Second year. Reason తెలుసుకోవాలి బాబు. That's why I'm telling you, understand the concepts. Then automatically not forget, right? MSI why pregnancy ఏమైతే cardiac output high output set up double cardiac both fetus and mother. So patient if he has placenta is again some place where it takes about 7 of blood, 1-2 liters of blood. So if a volume overloaded condition, if there's some other secondary chamber like placenta, then regurgitation lesions will all decrease. Okay. In pregnancy, regurgitation lesions symptoms decrease, not increase. Whereas stenotic lesions, the cardiac output has to go through double again. It has to go because both mother and fetus has to get supplied. So stenotic lesions manifest more in pregnancy. Okay. In pregnancy, mitral disease got precipitated. It has to be stenosis. It cannot be regurgitation. Regurgitation, okay. Regurgitation when it can worsen and regurgitation lead to severe PAH. Again, it becomes like obstruction. pH level is obstruction. Then it manifests again. MR with severe pH. By and large, the patient does not have severe pH. MR doesn't worsen. AR doesn't worsen. On the other hand, patient symptoms might decrease a little because placenta acts as a second chamber, second barrier to decrease the distance. So regurgitant lesions symptoms will decrease for that reason. Stenotic lesion, symptoms will increase. So this is diagnosis done for you. Pregnancy, stenosis, balloon treatment done. Diagnosis is done in first 3 lines. No? But my area first, we should ask later. Okay, go ahead.
She has since 10 days back. And then she has developed chest pain.
What are the other diseases which you worsen in pregnancy with other code? Because they'll ask you some question. One is mitral valve disease, I said. What else can worsen? Well, you should know 10 causes of pregnancy. You should thorough in pregnancy. No, but anybody should be thorough, but more so for you. Tell me, you should tell at least 5 causes of worsening in pregnancy. What is this? MBBS student should tell this. No? What? Tell them.
Anemia.
Okay, good. Anybody can test help, but no problem.
Heart failure.
Huh?
Heart failure.
What heart failure? Heart failure only you thought. Why heart failure?
LV dysfunctions.
Now, what are you doing? To tell correctly, no, in the questions, huh? What happens in pregnancy? What are you doing?
Stenotic, aortic stenosis.
Less likely. These things can happen. But you should get that first to know. Pregnancy, LV dysfunction means pericardial cardiomyopathy. We should be thorough in it. We are masters in it actually. We have collected some 58 patients of pericardial cardiomyopathy. Lot of cases come in our country. Unfortunately. ఎందుకు సన్నగా ఆయన 18 పెళ్లి చేసేది ఇంత ఉంటుంది ప్రెగ్నెన్సీ అట్లా సో విలేజ్ ఇట్ క్వైట్ కామన్ పెరిగిపడకుండా నెక్స్ట్ ఇట్ ఈస్ చాలా ఇంపార్టెంట్ ఎంటిటీ యూ షుడ్ టెల్ ఏందమ్మా ఉన్నాయని డిసీజ్లు వెరీ సింపుల్ ఏది థింకింగ్ సో మచ్ కన్జైల్ ఆడేది ఒకటి ఓకే వాళ్ళ ఆడేది ఒకటి ఓకే నేను ఇంకా మైకార్డియల్ డిసీజ్ ఒకటి ఈచ్ దానికి ఒక్కొక్కటి చెప్పచ్చు కదా కార్డియాలజీ సో ఈజీ ఒకటి పెరికార్డియం డిసీజ్ ఒకటి పెరికార్డియం మైకార్డియం వాల్వర్ డిసీజ్ ఒకటి జనరల్ డిసీజ్ సింపుల్ నో దెన్ లంగ్ కాల్చుకోండి లేదు హార్ట్ రిలేటెడ్ లంగ్ పిహెచ్ డెవలప్ అయితే మోస్ట్ ఇంపార్టెంట్ ఇస్ ఎనీ డిసీజ్ విచ్ కెన్ విచ్ ఆల్రెడీ లెడ్ టు పల్మనరీ హైపర్టెన్షన్ వర్సన్ ఇన్ ప్రెగ్నెన్సీ ఇప్పుడు ప్రైమరీ పల్మనరీ హైపర్టెన్షన్ ठीक है then otherwise then
Any cause of isomalization.
pH situations either isomalization or primary pH anything can work right or else heart failure you said pericardium then anything in pericardium ante pericardium particularly pregnancy ki ledu but any pericardium anything also infection particularly pregnancy and ledu kada it can happen that way but by and large, it's not described. But myocardial disease is described, valvular disease is described, general disease is described, right? But I wanted to remember pulmonary hypertension. And any severe can worsen again. Severe PS can worsen, severe AS can worsen, any hemodynamic significant disease can worsen. Okay. So pregnancy worsening at a particular cause of Japan. Okay. ARMR Japan. Then examiner will catch you there. ARMR is supposed to be decreasing symptoms. Then you have to substantiate yourself saying severe MR lead to severe pH can sometimes worsen or severe MR with LV dysfunction can worsen all that. If LV dysfunction is there, anything can worsen. Right? The congenital disease?
Scientific.
What's that? PhD. I said, we said okay. pH situation, ASD, pH going to isomere. Inkem congenital? Cyanotic or cyanotic? No? Cyanotic, what is your skills? That's okay. Coagulation also can worsen. That is also a cyanotic. Yes, there is extremely high chance of coagulation perianeurysms rupturing during pregnancy. That's why we don't advise coagulation during pregnancy, especially the coagulation is severe. And one more thing here, pregnancy reminds me, I keep telling in every place, every lecture, movement of fashion, advise MTP. MTP is killing a child, no? The fetus. It's a last resort. But chinna MTP doesn't. Saving is great, writing MTP is no great, man. Okay? Discuss with the patient, parents, kids. They want to continue to save the baby. We are there to save lives, not to kill. Mild MR. moderate MR, small ASD, mild LV dysfunction. All advanced MTPs, people have done and come also. They are struggling a lot since 2 years, 3 years for a precious child. Somebody is advised MTP. So that is not correct. Even the sickest of the sickest wants to deliver it, we should try to keep it. Explain the risk to them. That's how we are supposed to give therapy, MTP రాసేదానికి ఏంది క్వాక్ కూడా చేస్తారు no why should you come to Apollo hospital but discuss with the parents already have the 10 children they don't advise the precious baby they want to continue they want to have it you have to protect I have seen patients all sickest of the patients delivering now high risk means what how much risk it
Less than 1%.
మీరు ఇంకా ఎక్స్ట్రీమ్ నేనే దాన్ని అష్యూరింగ్ చెప్దామంటే మీరు ఇంకా లెస్ దెన్ 1% around 10%, 5 to 10% is high risk. 2 to 5% is moderate risk. Less than 2% is one mild risk. 1 to 2% is mild risk. 10% is high risk also. 90% still normal delivery. Normal things can happen. Yeah. So if you take care, then 10% can decrease it to 1%. So don't advise MTPs left and right. In future, you will also become physician. That's why I'm saying. అమ్మాయిలకి ఎక్కువ కన్సిడర్ ఉండాలి కదా లేడీస్ వెంజన్స్ రాసిన పేషెంట్ కూడా ఉన్నారు డాక్టర్ కూడా ఉన్నారు సారీ టు సే దిస్ సో బట్ యూ షుడ్ ట్రై టు సేవ్ ఆల్ దిస్ ఐ హావ్ సీన్ టెక్నాలజీస్ డెలివరీ ఐ హావ్ సీన్ ఐసర్మీనియస్ డెలివరీ ఓకే ఐ హావ్ సీన్ మైట్రస్ నర్సెస్ కొల్లలు we have done BBMVs and patient not able to lie down we did BMVs so 52 LA pressure it becomes 10 then delivers normal that's where is the happiness of doctor other than writing MTP. So much stress doing balloon water or whatever in pregnancy is not easy. Patient won't be able to lie down, tachycardia will there. Still, you should do it. Saving patients will help us. Okay, debated. But at least what I'm saying is, last week you have taken this system. You should have studied, come with differential diagnosis of symptoms of worsening in pregnancy. You are thinking after one diagnosis you told me and thinking. So what I'm saying is practice this habit in exam. If you have time in half an hour, you always think what is the likely question the exam is likely to ask. Then you come out faster. Otherwise, you die in JVP. Yeah? So please go ahead.
So she had decided chest pain, which was progressive dragging type, non-radiating, no diurnal variation, aggravates on exertion.
Chest pain. Yeah, because I should learn something from you also. And any particular condition itself which varies in time.
Any muscular pain that while sleeping or waking up or something that is with any movement of the hand that she's having muscular pain.
That is different. Movement of pain is different. You said diurnal any syndrome or disease which increases at night or decreases at day. I am asking that diurnal variation is described for that, migraine. With the onset of sunrise, the headaches increase. Actually, the chest pain. Diurnal variation. To utter something, you should have some basis for it. That's right. It's just trying to get that culture and thinking process in you, not to criticize it, right? If it is relevant, you tell me, I will also learn now. Okay? Headache on that diurnal variation, correct. You should tell that will suggest you it is migraine. Right? You read somewhere just chest pain associated with husband's troubling or chest pain associated with wife's troubling could be there more at night. No? I don't know anything is described like that. In kids, something was described like that. I don't remember. What is that SID syndrome? The pain in the children will happen only when the parents are not there. When you leave it to the grannies, they will hit then they will have pain. Right? Something like that. But it's not relevant here. You can tell what are now you should know what to ask. You know correctly. If you know what are the features of typical angina. I already told this. Our idea is to distinguish why is the pain coming. That is the idea of history. Diurnal variation has no meaning for us to distinguish why is it coming. But there are some things which you miss. So you should know what is the characteristic feature of typical angina. I told this also. You tell me, how will you say typical angina?
The chest pain is radiating, which increases on exertion. Doesn't even relieves on rest.
I said 3 typical features. All the 3 are there typical. Two are there, it is atypical angina. One or none are there, is non-anginal pain. That's how you make it. It's not my thing. Everybody has described angina a long time back. And that one is there on the books. One is the character of pain. Please don't forget this. If somebody is asking what is typical, top you check them, the question discussion on does not. If you say a patchy thing, they will ask further. No, please remember this. Typical angina, it is trained in cardiology, good place. You should for it is angina is the bread and butter in life later. You should know clearly. Okay. So just this one is the character of pain. Character of pain is anginal pain is diffuse type of chest pain, heaviness, not localized or anything. And you can say crushing, you can say whatever various people might describe it different thing, but it's not a very focal pricking pain at all. It's the diffuse type of pain, chest constriction in type, retrosternal, radiated to both arms. That is the character associated sweating things also. So this is the character of pain. One. Second thing is how is that happening? Exertional factors in it. So all these symptoms will increase with exertion. Is the second important feature. Third important feature is decreasing with the rest are sublingual nitrogen. If all the three are there, it is typical. Two are there, atypical. One is there, non-anginal pain, non-cardiac. There's nothing called atypical chest pain. I told this also. No?
Yes.
I told. So if you remember and tell correctly, no, we can discuss something new. No? We're discussing the same again what we have discussed. Anyway, what has come new, I said in chest pain. Female should know this again. I told this source. Latest guidelines on chest pain said females are different. They have to be treated different. Chest pain is different in their nature. There are more incidents of atypical features of chest pain in female. They might present with more anginal equivalents, breathlessness. This is not my version. Described, I always tell females are special. They are copomusal. Huh? Why you tell like that, sir? You're not special. I'm telling you special. You should enjoy that specialty status. No, it is described in it. Non-cardiac chest pain, ACC guidelines actually, some 2022. In that it is written, females presentations are different. Yeah. On the other hand, many times typical anginas also, meerante younger, family low 40, 50 years, mothers, kids are 7 years, or a pain or something. They don't bother. Husband is a video వచ్చేస్తాడు. Ladies చాలా లేట్ అయిపోయి ప్రాబ్లం అనేది తీసుకొస్తారు అట్లా కూడా చూస్తారు. That's also wrong. Okay. So a lot of late presenters also described in women. Okay. So we deviate from chest pain. So chest pain, you have to ask here, chest pain, whether it is continuous or intermittent. So what is the character of pain? Tell me. Aggravating factors, we check on diurnal variation and question. So what is she has angina? The typical angina like you're telling. She has angina. Could be at 60 years of age, could be angina. But suppose you're thinking of valor, what else could be? Then one thing you tell me, you want this sort of discussion, you directly want diagnosis and case discussion. Because I see your face funny sometimes. The discussions from Chatta. No. Right? Last week who did it? No, what I'm saying is rotation is don't give this. You're not a small student now. Every developmental student, not every. No, it's good that you are given a chance. These are the things you should broadly decide, no? Who has to do what. Final years have to take the responsibility. Final years don't come, then Papa youngsters will work. That's okay. What I'm saying is take this as an opportunity, whatever I'm saying. But you have to follow that. If you people take interest, more interest will come to me. If you don't take interest, I'll also lose interest. No? But natural, no? The final years will the maximum people will benefit. The final years don't come, then what is it? No? Anyway, it's okay. So what is it? Okay, CAD is possible in this place. What else could be there? Until you have to know what are the other non-anginal type of causes. It could be still cardiac, it could be non-cardiac. Non-cardiac is anything can be non-cardiac. But non-cardiac, which mimics like this, unlikely. No, exertional increase, breast decrease, diffuse pain, they're unlikely. Non-cardiac and local pricking pain, increasing breathlessness, increasing the respiration, cough, things like that, you think as non-cardiac. What can be non-cardiac causes of chest pain? You know anything. Pleural pain, pericardial pain, back pain, bone pain, grip pain, anything can be muscle pain, anything can be non-cardiac. There's no issue. Cardiac, but not angina. What is it? Pericarditis is one. But here pericarditis pain is different. Pericarditis pain will be increasing with respiration, increasing with cough. It is more like pleural. Maybe continuous or but what cardiac pain can mimic angina? That you should know, especially when we are dealing with valvular disease. Patient develops PAH, RV strain, okay, right ventricular ischemia because of a relative put behaves almost same like angina. So if not coronary artery disease, you should tell, PAH linked to right ventricular ischemia could lead to same pain, you should tell. That could be in this patient because if you have an explanation, patient is God, the patient is final. You have to find your own reasons to say why the patient. You can't say patient is mad. Whatever complaint she has, you have to get a scientific conclusion, explanation for it. Understand? So you have to find a reason. Examiner will catch out, then you will tell you will then think this is wrong. I am trying to tell you, get into that. Sorry. Okay. Here it could be because of pH. That means it's giving you a hint that patient has significant disease where RV could have hypertrophied and we could be getting angina. Right? Okay, then. See the severity of chest pain. How will you do? This for every symptom is important. You have to understand whether it's chumma chest pain or serious chest pain. How do you do? Because somebody may have light pain, not bothered. Somebody may have severe pain. How will you know? You know pain gradings? Pain grading of pain, you know? 0 to 10. Ladies should know this, first, again I'm telling you this thing. What is the 10? Worst grade is what? Pregnancy, labor pain. Should know worst. The next worst is cardiac. Okay? So that's the worst. Chumma pain cannot be like angina pain or MI pain. MI pain, the next worst after labor. 9 grade. Okay? So you know that. Chumma pain she has, no? She doesn't have severe pain. So it's not MI. Could be some mild discomfort because of some pulmonary hypertension, that it's possible. How will you know? I'm asking. ఏమంటారు పేషెంట్ చెప్తారా గ్రేట్ 10/10 పెయిన్ ఉన్నా కానీ చెప్తారా పేషెంట్ హిస్టరీ అన్న ఓకే పేషెంట్ ఇట్లా అంటుంటే పెయిన్ ఎక్కువ అనుకుంటారు నేను ఎగ్జామినేషన్ చెప్తా అంటే వేరు హిస్టరీలో ఎక్కడ తెలుస్తుంది సివియర్ పెయిన్ ఓకే దట్ ఇస్ వన్ ఫార్మ్ ఆఫ్ ఇట్ సెకండ్ పేషెంట్ బాగా పెయిన్ వచ్చి పడిపోయాను సివియరా మైల్డ్ సివియర్ మరి చెప్పాలా మళ్ళీ మళ్ళీ నేను ఇంట్రెస్ట్ చెప్తాను. So severity of pain, you know, by pain is so severe led to syncope. Pain is severe led to some other problem. What is severe pain? That means real problem, not mild chumma pain. Okay. So how will you know the severity of palpitation? Also, I told you. Similarly, same symptom analogy. Any symptom, severity assessment, you have to do it. Like breathlessness, Cardiology, you know, functional class 1, 2, 3, 4, we kept it for that. Palpitation also, I told. Oh, what did I tell? Severe palpitation on the ELD. History palpitation. I did discuss this. No, we will not proceed further if you keep forgetting what I told them. No, I'm really serious about it. Please take it seriously. Otherwise, you're not bothered too much about what we're discussing. I get that feeling. If you just forget what we have discussed, where will you progress? This is particularly I told. It's not great rocket science what I'm telling you. It's simple. Palpitations, how will you assess the severity of palpitation? I told very clearly. Here you are not answering, then how will you progress further? We are stuck in history. Palpitations leading to syncope. Palpitations severe enough leading to angina. I did tell this, no? Then it's a real significant palpitation, that means it's not chumma palpitation. Chumma palpitation is only palpitation of valvular regurgitation, right? Suppose mild, some mild disease could also have palpitation. That means it's not very important, but palpitations lead to syncope. Serious? How will anybody, that is assessment of severity, understand? Same, every symptom you have to have that, right? Here she did that. She never had a symptom. Feel free, don't think otherwise. I don't want to trouble students, don't get me wrong. Okay, feel free, laughingly we should discuss. Don't take it seriously.
No.
Okay, you shouldn't feel bad also. So, syncope లేదు మరి నీకు చెప్తే కదా నాకు తెలుస్తుంది లోపల బ్రెయిన్ లో అనుకుంటుంది. అచ్చా నెక్స్ట్ ఉందా సార్
Patient had palpitation.
palpitation అంటలేదు చెస్ట్ పెయిన్ అయిపోయింది కదా చెస్ట్ పెయిన్ సీరియస్నెస్ కూడా నాకు చెప్పలేదు నాట్ కన్వేడ్ మీ హౌ సివియర్ ఇస్ ద చెస్ట్ పెయిన్ యు నౌ మూవింగ్ టు palpitation palpitation లో సింకోప్ చెప్తారేమో బట్ చెస్ట్ పెయిన్ ఆల్సో ఐ హావ్ టు నో అండర్స్టాండ్ ద సివియారిటీ ఆఫ్ చెస్ట్ హౌ ఇట్ ఇస్ మైల్డ్ ఇంటెన్సిటీ మోడరేట్ ఇంటెన్సిటీ సివియర్ ఇంటెన్సిటీ అని చెప్పాలి టైప్ ఆఫ్ పెయిన్ చెప్పినప్పుడు ఇంటెన్సిటీ ఆఫ్ పెయిన్ యూ కన్వే టు ద హిస్టరీ రైట్ palpitation
Patient complaint of having palpitations intermittently, not associated with syncopal attacks.
First, anything syncope important first syncope work. First, if standard format you follow, mode of onset, duration, progress, then severe, right? So then type of palpitation, regular, that will come next. Okay. So palpitations, palpitations, all follow the same. Okay. What atlete miss if you follow these 5 things, it becomes easy for you to express anything. Palpitations is there since 2 years, so 2 years, so whatever. When did you first notice whether they're increasing or decreasing from that time? The regular, irregular. Then comes the severity. Okay. How did the palpitation increase? How did it decrease? The aggravating factor, the limiting factor. For everything, you should tell these 5 things. Every symptom. Then some specific things. Okay. The palpitation regular, irregular. Irregular. What does it mean? Very important. I told the diagnosis again. What does irregular palpitation mean in this patient? Yeah, good. Regular palpitation. Associated MR. Okay. So irregular palpitations are more common in MS. Why? Because atrial fibrillation is more common in MS. Okay. So you told the diagnosis now, you know the complication also now in the history itself. Did I tell you last time? Till you go to in undergraduation, you keep thinking, and post-graduation also sometimes you think auscultation is everything. By the time we go to the auscultation stage, we know the diagnosis. We just confirm what is there, the findings in the auscultation. That's all. Auscultation, that's. On the youngsters, when we are undergraduate, everything in auscultation only we used to think. But if you learn proper cardiology, by the time you go to auscultation itself, your diagnosis is out. You just confirm the findings of auscultation. That's all it is, right? So now you know if patient is likely to have an atrial fibrillation or no. So if palpitation is atrial fibrillation, what else is important to ask is atrial fibrillation? You said irregular palpitation. What is the other important complication of atrial fibrillation? Why were so much bother about it?
Thrombotic risk.
You have to tell me that. Cardiology is okay. I'm saying atrial fibrillation. Cardiology is.
She had any history of previous history of any congenital heart disease.
No, I'm asking atrial fibrillation importance. Is thromboembolic episodes irregular palpitations, but there is no evidence of any syncope or loss of consciousness or weakness in any other limbs. When palpitations you're telling that you should tell them, right? Okay.
So she had irregular palpitations, fast, not associated with any precipitating factors or relieving factors. Patient also complained of shortness of breath.
So palpitations are there same like that from before to now. You think that's useful? Use this or that? No. You know, score is waste. Same palpitations are. We are not reviewed anything of patient. What are you doing here? In 20. Okay.
Previously,
Yeah.
she didn't tell anything.
At least you should
But
tell.
since 10 days, duration of 10 days, she had irregular and fast without any
So
precipitating.
that is telling you that these 10 days atrial fibrillation could have had, which has led to increase in symptoms. Very good point. Okay. The worsening features of chronic disease, though, what is worsening, you have to identify. What are the causes which can worsen the pre-existing cardiac disease? This is what is atrial fibrillation onset is one of the most important. Right? You got it. Second, what is most important? What are the causes which general chronic disease can worsen? Infection, any fever, infection, paradoxicosis, thyroid disease, anemia, all that. But arrhythmia is the most common, atrial fibrillation, right? Okay. Then
Patient had history of patient had shortness of breath since 1 week. It progressed from slight limitation of activity to SOB at rest from grade 2 to grade 4.
Big difference. Telling you so many times. You're saying breathless is 1 week. Seriously, never had.
She told because she told chest pain with palpitations and said
So breathless, so no.
short. Yes, sir, but once first chest pain, then progressively she had shortness of breath.
Breathlessness was not there for her before.
This 1 week, it was great. Grade 1, grade 2 only, sir.
చెప్పండి great way చెప్పండి.
So progress to grade 5 in this 1 week.
That you should tell now then. You're telling breathlessness is 1 week. That means I think of acute condition. No, why I am concerned about 1 week is reason. Please understand the reason why you are catching 1 week and 1 week had different connotations. So 20 years of breathlessness is also now. 1 week. 20 years she is suffering with breathlessness and palpitations. Not now. It became better after procedure. She's typical example of natural history. That's why I'm specifying so much. Did some procedure, breathlessness is gone. Huh? 4 o'clock come. So OT5 signature ante pedtali. So what I'm saying is, so breathlessness class 2 now was sent to class 4 with the onset of palpitation. Agreed. Atrial fibrillation was sent to class 4. Pakka diagnosis clear. No fever but atrial fibrillation. Like that you should tell. What is the other important thing last in breathlessness? Ma, I'm happy that you told this. Orthopnea and PND must. Why must? No, left sided or right sided, you know by that. Okay. If it is PND means it has to be left side condition. Your diagnosis will be more focused, already clear. Breathlessness with PND, orthopnea could be there sometimes the right side also. But it's sometimes complicated what to do, what you take it. PND, classical pulmonary venous hypertension. Breathlessness PND means it has to be either dysfunction or to be obstructive valvulitis. Right? Is there? The PND is there for? You didn't ask.
I didn't ask for PND, sir, but she.
Regardless, that is most important.
She has.
Then, if orthopnea she's telling you orthopnea, it's mandatory for you to ask PND. No? This is all learning, but never forget PND inquiry, breathlessness. It is real. Some things which are very light, I don't insist actually. Please don't get me wrong. Some things is very important, you should never forget. If you forget PND history in breathlessness, what you are? No?
We asked, sir, we asked, but we're not sure whether she really had it or not.
That's what you are analyzed. You have to use your brain for that. Okay? That's your inference is that only. Like line number, you have to decide whether it has PND or not. No?
Yes.
You know the reasons of PND. Again, I don't want to go into it. You have every exam last telling you. No? What is the etiological kind of pathological phenomenon behind the PND? Why is she not listening other way? Why is she becoming listening only at rest, you know? What is that? 2-3 reasons describe what you should tell, then we will progress further. No? After PND, the typical reasons is one is increased venous return. Patient is lying down, but venous return is there. This time lying down also. Something else also should be added for it, apart from ortho. So what is the sympathetic driving? Then, third, read again. If you tell 1, 2, 3, then we'll push progress further in exam. Otherwise, we'll get stuck there. Right? Okay, breathlessness is over. Now we're suggesting there is left side mitochondritis. Okay? Next.
She had cough, cold, and fever since 10 days, which relieved on medication.
You did tell me other. So other important complaint was.
Complaints of pain in the throat.
Then you did tell me change in the voice. That's why she came.
Since 10 days.
Good question.
Yes, I asked.
First complaint I watched patient patient came with very specific complaint. Okay, evaluation typical what is done outside is done like that. You come to right doctor, you will identify correct. Throat pain, hoarseness of voice. నా గొంతు బొంగుపోయిందని వచ్చింది. So what is that? Diagnostics. So see that diagnosis is coming to you straight. She's telling directly what all she has. No? What is the mechanism for that? You know?
Left heart.
I didn't know. It's compressed by what?
Atrial enlargement compressed inflammatory.
Not left ventricle.
Past history, she had undergone a procedure.
Rheumatic history.
20 years back, she has had some fever and symptoms. She told
You didn't tell me that she has rheumatic fever in the past history.
she told 20 to 25 years back, she was
There is still fever.
diagnosed with a heart condition for which she was taking medication and she
No,
stopped.
history of rheumatic fever ఉందా లేదా అని చెప్పాలి స్పెసిఫికల్ నెగటివ్ పాజిటివ్ ఓకే అని ట్యూబర్క్లోసిస్ ఎట్లా చెప్తారో వెల్నర్ డిసీజ్ యు స్పెసిఫికల్లీ మెన్షన్ వాట్ హిస్టరీ ఆఫ్ rheumatic fever నాకుంటే లేదని చెప్పండి ఓకే
She's a known case of hypothyroidism since 20 years. She's been taking
అవునా
medication.
అది కూడా ఉందా
Yes, hypothyroidism.
So that also can lead to hoarseness of voice then I didn't realize ఓకే ఇప్పుడు ఏదైనా వచ్చింది అనుకో ఇట్లా దాని డిఫరెంట్ డయాగ్నోసిస్ మీరు గుర్తుపెట్టుకొని చెప్పాలి మీరు hypothyroidism one of the different diagnosis of voice right laryngitis also can be there the investigator outside for laryngeal palsy vocal cord palsy that also can be there right
And she's taking big oxen, some she got some heart medication I'm taking for 5 days and not on the weekends.
why is it always like that you know
Toxicity.
very common